Next up, we're diving into the realm of ear, nose, and throat diseases. This comprehensive presentation will explore a wide range of conditions affecting these vital sensory organs, from common ailments to more complex disorders. Get ready to delve into the intricacies of ENT health and learn about the symptoms, causes, diagnostic approaches, and treatment options for various ear, nose, and throat conditions. Acute otitis media is an inflammatory condition of the middle ear, commonly seen in children. It typically occurs due to bacterial or viral infections, as well as exposure to environmental allergens or irritants. Children are particularly susceptible to acute otitis media because their eustachian tubes are shorter and more horizontal, making it easier for bacteria and viruses to reach the middle ear. Symptoms of acute otitis media include ear pain, irritability, disrupted sleep, crying, and often accompany upper respiratory symptoms like runny nose and cough. Diagnosis involves observing a red bulging tympanic membrane that is less mobile upon pneumatic otoscopy. Otitis media with effusion, also known as glue ear, is a related condition characterized by fluid in the middle ear without acute infection. The primary treatment for acute otitis media involves antibiotics, with amoxicillin clavulanate being the first-line choice. Pain relief medications such as acetaminophen or NSAIDs can also help alleviate discomfort. In cases of recurrent or severe acute otitis media that doesn't respond to standard treatment, tympanostomy tubes may be surgically placed to ventilate the middle ear and prevent fluid accumulation. Differentiating acute otitis media from otitis media with effusion and chronic suppurative otitis media is crucial based on symptoms and physical examination findings to ensure appropriate management. Otitis media with effusion is a chronic condition where fluid accumulates in the middle ear without the acute symptoms seen in acute otitis media. Patients with otitis media with effusion typically experience a sensation of fullness in the ears, but do not exhibit the typical signs of otitis media with effusion such as pain, irritability, or fever. Unlike acute otitis media with effusion typically does not require antibiotic treatment because the fluid in the middle ear can hinder the effectiveness of medications. However, patients suspected of having learning disabilities should be evaluated for conductive hearing loss stemming from otitis media with effusion. Chronic suppurative otitis media is a chronic inflammatory condition of the middle ear that arises as a complication of recurrent acute otitis media. Characterized by a perforated tympanic membrane and persistent ear discharge, chronic suppurative otitis media can lead to the formation of cholesteatoma, granulation tissue, and polyps. Additionally, it can cause both conductive and sensorineural hearing loss, distinguished from acute otitis media and otitis media, with effusion by the presence of a perforated tympanic membrane and persistent ear discharge. Chronic suppurative otitis media requires treatment aimed at controlling the infection and preventing complications. This often involves a combination of topical and systemic antibiotics. Otitis externa is an inflammatory condition that affects the external ear canal, contrasting with the middle ear involvement seen in otitis media. Frequently associated with swimming or exposure to moisture, otitis externa is commonly caused by the bacteria Pseudomonas aeruginosa. In immunocompromised individuals, a severe variant known as malignant otitis externa can develop, leading to aggressive osteomyelitis of the mastoid and skull base. The primary treatment for otitis externa involves the use of topical antibiotics, such as ofloxacin, along with topical steroids. Pain management may also be necessary utilizing medications like acetaminophen, NSAIDs, or opioids to alleviate discomfort associated with otitis externa. In instances of malignant otitis externa, systemic antibiotic therapy and vigorous management of the underlying osteomyelitis are imperative. Benign paroxysmal positional vertigo, BPPV, is an inner ear disorder characterized by sudden brief episodes of vertigo triggered by head position changes. Diagnosis of BPPV typically involves the Dix-Hallpike test, which elicits vertigo and nystagmus. The mainstay treatment for BPPV involves repositioning maneuvers, including the Epley, Brandt-Daroff, and Simont techniques. These maneuvers aim to relocate displaced inner ear particles, alleviating symptoms of vertigo. Meniere's disease is an idiopathic inner ear disorder characterized by a triad of symptoms: vertigo, tinnitus, and sensorineural hearing loss. The condition is believed to arise from abnormalities in the endolymphatic fluid composition, resulting in damage to the vestibular and/or cochlear systems. Treatment of Meniere's disease typically involves lifestyle modifications, such as adopting a low-salt diet, along with the use of diuretics to regulate fluid balance within the inner ear. Vestibular schwannoma, also known as acoustic neuroma, can result in several symptoms due to its effect on the vestibulo-cochlear nerve. 1. Hearing loss. The tumor's pressure on the vestibulo-cochlear nerve can cause unilateral sensorineural hearing loss. 2. Tinnitus. Patients may experience unilateral tinnitus, likely stemming from the same nerve compression. 3. Vertigo. Vestibular schwannoma can induce vertigo and balance issues by impacting the vestibular component of the vestibulocochlear nerve. 4. Trigeminal nerve palsy. In some instances, the tumor may lead to trigeminal nerve palsy, manifesting as facial numbness or pain. Labyrinthitis, also known as otitis interna or vestibular neuritis, entails inflammation of inner ear structures like the vestibule and cochlea. This condition can be triggered by viral infections, such as herpes simplex virus, HSV1, or bacterial and non-infectious factors akin to those in acute otitis media. Patients grappling with labyrinthitis may endure vertigo, nystagmus, hearing impairments, nausea, and vomiting due to vestibular and cochlear system involvement. Typically self-limiting, labyrinthitis generally doesn't necessitate specific pharmacological intervention, although symptomatic relief with antihistamines or antiemetics may be beneficial. Vasomotor rhinitis represents a non-allergic manifestation of rhinitis, marked by chronic nasal congestion, polyps, and hypertrophic turbinates. Viral rhinitis, commonly known as the common cold, is another non-allergic form of rhinitis, typically accompanied by upper respiratory infection symptoms such as sore throat, sneezing, and headache. Rhinitis medicamentosa stems from the overuse of topical nasal decongestants, resulting in rebound congestion, a non-allergic subtype of rhinitis. On the other hand, allergic rhinitis, or hay fever, constitutes an allergic manifestation of rhinitis characterized by seasonal symptoms, clear nasal discharge, and often associated conditions like asthma and conjunctivitis. Sinusitis, also known as rhinosinusitis, refers to inflammation of the paranasal sinuses, frequently coexisting with rhinitis. Various factors, including viral, bacterial, or allergic triggers, contribute to sinusitis, often linked with underlying conditions such as cystic fibrosis and asthma. Typical symptoms of sinusitis encompass nasal congestion, facial pain and pressure, cough, sore throat, and headache, with the location of symptoms corresponding to the affected sinus cavity. Complications of sinusitis. 1. Osteomyelitis. Chronic or recurrent sinusitis may progress to osteomyelitis, a bone infection, as a serious complication. 2. Orbital cellulitis. Sinusitis, especially affecting the ethmoid sinus, can lead to the spread of infection to the orbit, resulting in orbital cellulitis, a critical condition necessitating immediate treatment. 3. Halitosis. Chronic sinusitis can also cause halitosis, persistent bad breath, due to the chronic inflammatory changes associated with the condition.